any other new legislators. So, Dr. Larson, why don't you go ahead and do your presentation? Hopefully people will join us because it is 2 minutes after. So go ahead, Dr. Larson.
Okay, let me thank you very much, Madam Chair and members of the committee. It's always my pleasure to come before this committee. And why is it not letting me share? Oh, can you see that? Are you able to see that, Madam Chair?
Yes, we are, Doctor.
All right, thank you. Well, it's always the pleasure to come before this committee. I have come before this committee for almost 20 years in describing what we've done with the tobacco settlement at the University of New Mexico Health Science Center. It's been a tremendous impact on our ability to fulfill our mission. And I'll go ahead and review that today and our request for next year. As long as this, here we go. How about here? So just as a reminder, the Health Science Center plays a critical role, as all of you are very, very aware, in delivering healthcare services, training of health professionals, and contributing to New Mexico's economy. We employ over 10,000 people here at the Health Sciences Center. One of the things I always like to remind people is that an academic health center, which we are, is different than other healthcare providers. We're neither purely academic nor purely healthcare. We have to compete in the marketplace like other healthcare providers, and that's different than, say, a regular university. But at the same time, we educate the workforce of tomorrow, and mostly in the clinical platform, and we engage in biomedical research that brings the latest treatments and the greatest state-of-the-art technology to the patients and people of New Mexico. At the HSC, there are several critical needs programs in patient care, education, and research. And those are the programs that provide the tobacco settlement provides the very foundational funding for, and that's why it's so important. This funding is leveraged, as I'll show you, many, many times. And so we get between $8 and $20 for every $1 invested in this program from the federal government. This is just to remind you that we always like to say that the UNM Health Science Center is the largest academic health center, or has the largest campus in the United States, because the entire state is our campus. And here you can see all the different locations in which we have different types of activities. The tobacco settlement goes back to around 2001, and when that agreement was formed with the tobacco companies, the legislature, in its wisdom at that time, allocated money that would come to the Health Science Center to support clinical care education and research. It specifically called out biomedical research and the importance of funding it. This just shows you one of the projects that was funded with tobacco settlement funds, and I'll go into how we do this a little later in my presentation. But this study basically showed even mild alcohol consumption or smoking by pregnant females could result in long-lasting effects to their offspring. And so the more we learn about tobacco-related illnesses, the more we find out their adverse effects and how important it is to find ways to treat them and, more importantly, prevent them. This just shows you quite often when it comes to research, people don't realize that we do our research, whether it be clinical trials or device trials or a whole variety of school-based trials, for instance, among adolescents to try to decrease obesity, occurs throughout the state. And this just shows you all the different sites that we currently do research in New Mexico. One of the other things that's important to distinguish is the cigarette tax versus the tobacco settlement. The tobacco settlement supports tobacco-related research and clinical care at the entire Health Science Center. The cigarette tax, which is not what I'm talking about, not presenting, supports the clinical care, education, and research at the UNM Cancer Center. So this portion of the money goes to all the tobacco-related activities we have that are not at the Cancer Center. The Cancer Center gets a portion of the cigarette tax for supporting its activities in this area. One of the things that not everybody realizes is how many tobacco-related illnesses there actually are. Everybody knows cancer, and there's 12 major cancers. They're not all listed up here that are related to tobacco use. But in addition to that, there's many different other diseases, chronic diseases, that are listed up here that relate to chronic tobacco use. This is the change in the funding since 2001 that has come to the Health Science Center from the Tobacco Fund. You can see overall that it's steadily decreased, and our request for next year, as I'll show you in a later slide, will be for it to stay flat. You can see in 2007 and 2008 there was an increase in tobacco settlement funds, but that green bar is the part of the tobacco settlement funds that have been committed to replacing ING. And that's always been kind of a funny manipulation that occurred in 2007 and has carried forward with this settlement funds and is buried in the allocation. So these are the projects that are funded by the Tobacco Settlement Fund. The core projects are the Poison Center, and the Poison Center gets funding from two sources, this source and from an RPSP. Our pediatric oncology program, our biomedical research program. This is the only funding we receive from the state for biomedical research, and I'll show you we receive a tremendous amount of matching federal dollars as a result of that. And instruction in general funds that were put in that green bar are shown here and relate to really providing salary support for faculty who provide specialty education in trauma and pediatrics. Just as a way of reminder, the Poison and Drug Information Center is a tremendous asset. It receives over 23,000 calls a year. Many of these, as you would say, suspect, or even most of them, are parents very concerned that their kid just ingested some possible poison. These calls, they really improve the health, not only, but they improve the costs. They prevent hospitalizations. People are able to either initiate having their kids take charcoal, for instance, or vomiting, if depending on what may have been, or just telling the parent not to worry. And so it's a tremendous asset to New Mexico and our state. The pediatric oncology program, this is assistance and part of the support that our oncology group gets that treats children with cancer. This is just to explain what I tried to explain what happened in 2007 with part of ING requests coming from the Tobacco Settlement Fund, and you can see that on the bar graph, and I'll have it on a line item in the total amounts in a later slide. And so the benefit of this money is really the additional faculty positions that come to the university and support the specialized educational programs, particularly in pediatrics and trauma that I mentioned earlier. So then there's about $937,000 of the tobacco settlement that really comes to the Health Science Center for biomedical research. So this is the research that brings new treatments, new devices, new ways of holding down pediatric obesity in middle school, and even basic science discovery too of what happens in a test tube. In order to get funding from the federal government, you have to have preliminary data. If you're a faculty at the Health Science Center, we don't have any research funds. So we have to go out and compete for it, mostly from the federal government, sometimes from companies, sometimes from foundations like the American Lung Association, the National Juvenile Diabetes Association, the Alzheimer's Association. And we have to compete against other faculty, many of which are at big name institutions. In order to do that, you need some preliminary data that whatever you're going to work on has a chance of working. So you need pilot funds. Well, if you don't have any money, you don't have pilot funds. And so the most critical thing that this program does is provide that pilot funding, and I'll give you some examples. For every dollar from this program that goes into pilot fundings, $8 to $20 of federal or private dollars comes to the Health Science Center for research into these other diseases. And so it's a tremendous return on investment from this investment. So this just summarizes exactly what I just said. You need pilot funding, you get data, you go get an extramural grant. It returns a very large number of dollars per dollar invested. The reason it's range is 8 to 20. It depends on what pilot is funded, and it depends on what year we funded the project. So that's a long-term return of the last 19 years. Every dollar invested has returned $8 to $20 into this back to the state of New Mexico for faculty to hire staff and supplies to do research that will impact and improve the health of people in New Mexico. So this is an example of one pilot funding. We invested $50,000 in a pilot fund. That pilot was to develop a handheld device that way back when, if you remember it, that was the white powder problem. White powder was being shipped to legislatures in envelopes in Congress. And we said we could develop a device that you could put the white powder in, and within 2 minutes, it could tell you if it was anthrax or not. And we immediately got, because we had a preliminary device we could build with that 50,000, 1.3 million for 8 years with our colleague from Sandia. And we built a device that actually worked. We won an award from the Defense Intelligence Agency for our contribution to national defense. And then we took that device and said, let's build it into something that can be used medically. And it was adapted first to detect influenza, and then Ebola, and now it's being worked on to detect COVID. And so this is a tremendous opportunity, an example of how a small amount of money can have a high impact and bring in significant larger amounts of dollars. I'm just showing you some of the research that goes on and that has been supported by this as we go through. It also supports some core facilities. One of the things we do in bioscience at the health sciences or health sciences research is equipment is really expensive. So we can't buy an expensive piece of equipment for every single investigator. We can buy it for the whole institution. And so that's what we tend to do. And then we share it to save costs. And it's made us really able to do a lot of different things. Included in those sort of core facilities that we support, we actually help and build clinical trials. And that's shown here. I just wanted to give you a snapshot just to give you an example of how many clinical trials are going on at any one time here at the Health Science Center. Right now we have 55 studies involving diabetes, 35 involving pulmonary studies, and so forth. Since the COVID crisis began, we have 42 different clinical trials in COVID. So we have the convalescent plasma studies going on here. We are testing several new drugs that might work in COVID. We have signed up for some vaccine trials. So hopefully if we get some of those trials, we'll be able to offer those as well. Now remember, one of the other advantages of a clinical trial is that any person that participates in it, their care is free. The care that the clinical trial gives is free. And so it has that added benefit as well. And we are able to develop this centralized clinical trial support structure because of this funding. Here's another example of some research that was done in colon cancer. And it showed that one of the things that causes colon cancer to metastasize is when not enough oxygen gets to the tumor, and that oxygen gets there through blood. And if it doesn't get there, it's more likely to metastasize. So here's a very busy slide, but it just shows the impact of what goes on with these dollars. So with the small amount of money we get every year, we're able to parlay that into several million and a significant number of jobs as a result. The UNM Health Science Center, just so you know, has built this up, but then has continued to build other sources too. And last year, we brought in over $200 million in research funding from the federal government, private companies, and foundations into the state of New Mexico. That employs approximately 2,000 people. And those 2,000 people are doing research that impacts and improves the health and wellness of New Mexicans. And so it has a tremendous impact on what actually can happen. If the funds go away, then we can't get the leverage and it scales down. Here's another interesting invention. This is an invention that you can breathe into, and it tells you if you've been taking certain medications. So a lot of people don't take their medications. So this gentleman has developed, he's a faculty member here, developed a device that helps tell if you've taken your medication just by blowing in it. And so that's an interesting machine that we're trying to build and commercialize with this company, Avisa. So how often, the other thing is, all of those dollars we bring into the state from the federal government and foundations and private companies. But in addition, when we do that research, new discoveries get made and our faculty patent those new discoveries. We can then license those patents to entrepreneurs who start up new companies. And since 2004, 60 new private companies were spun off from the UNM Health Science Center from our discoveries. And a number, but not all of those logos are shown here. 34 of them are in New Mexico. Of those 60 new companies, 24 have relocated or started up in other states, and 2 are outside the United States. And so what is shown on my last slide, or nearly my last slide, is the FY21 amount that we got for each one of these programs in the tobacco settlement. And our request for next year is to have that remain flat. We understand the pressures the state is under and the pressures that the tobacco settlement is under. Just want to point out that if there was a loss of funding, it does impact our patient care services directly. It does definitely decrease the number of jobs, particularly the number of research jobs we have in our economy. there is a loss of economic activity for sure. So with that, Madam Chair, I was scheduled for 30 minutes, and I've given myself at least 8 minutes for questions. So thank you.
And we started 2 minutes late, so you might get 10 minutes worth of questions.
Okay.
So is there anybody with a question? Just unmute yourself and interrupt me if there is. Okay, while they're thinking, I have a couple, Dr. Larson. So when you talk about the machine that you blow into that detects if you've taken your medication, are there certain classes of medication that works for, or is that universal?
That was originally designed and is first being developed for drugs used to treat TB. One of the, particularly in urban environments, if you do have TB, which we still have quite a bit of in this country, it's very highly infectious. And when you stop taking your medication, you become very infectious. And so, and a lot of those patients need their medications delivered to them. And the idea is you'd be able to test the patient right when you deliver their drugs and show that they've been taking their drugs and will continue to be taking their drugs.
Okay, and just this is a little bit off topic, but I don't know whether you would hear it or not, but you talk about medications, and I've been concerned lately about the slowness in mail. Are you hearing anything from particularly any of your trial patients that are having, but any of your patients that are having difficulty with the slowdown in the mail system?
I haven't heard any about specific cases, but as you know, the mail system did slow down quite a bit during COVID for everything. So I don't think it was targeted at drugs. I just think the mail system got slow. One of the advantages of the way we run our clinical trials is we generally have the drug stocked ahead of time. So even during the COVID crisis, when everything went into shutdown, we continued to see those patients that were enrolled in clinical trials so that they could continue to get their medication as they needed it every couple of weeks for most of those trials. And so we never shut down. We moved to very safe COVID safe procedures. So patients could come in, especially when they had a drug that they needed to come in and get. There's certain drugs that you take by mouth, you just need to pick up, but there's other ones that you really need to be checked up on, even if you're taking it by mouth. And then there's others that would have to be infused.
Okay, thank you. And then and this may be a long and complicated answer, and if it is, just tell me so. So when you talk about the commercialization of things that you've developed at UNM, how does it work that you essentially get paid back for what you've invested?
Well, it sounds like we should get paid back, but you don't get paid back for that.
Okay.
So it's kind of a most of the money that we really get for research comes from the federal government, private companies, and foundations. We apply, we compete against other faculty at other universities. An agency at the federal government, like the National Institutes of Health, examines 100 applications and they give 10 awards. The money that come from those awards is how a faculty member hires people in New Mexico, how they buy their supplies, they buy their equipment, how they move forward. The pilot funding they need for that to occur comes from the tobacco settlement. Now, if they're really successful with their research and they do something that's patentable, now that patent can be licensed to somebody and they can license it to an entrepreneur, and the entrepreneur can build a product and sell it. in any given year at the Health Science Center, we bring in $200 million from the federal government and outside foundations, all into New Mexico to do that research. The amount of money we get from the licensing is hundreds of thousands of dollars. It's nothing relative to the large pool of the other activity. But even, and so it's actually a loss leader for us. We invest more money in trying to do that activity to start a business than we get returned. But it's important to do because every time we help start a company, it builds jobs and that company can potentially go somewhere. We don't benefit from that at the Health Science Center, but that company does if it's successful, and the employees of that company and the product that they produce is beneficial to the state of New Mexico.
So the patents, Dr. Larson, belong to the research, like the key researchers, the principal investigators.
It belongs to the university, but there is a agreement to split if they're able to make some small amount of return of money from the patent. There is a split between the inventors and the university.
Okay. Representative Chasey, are you still on? I guess not. So here's what she said. I have to attend a court hearing in a few minutes, so we'll be gone for a while. But I wonder if Dr. Larson has had a recent opportunity to take this information to the LFC about the dollars leveraged by the investment of tobacco settlement dollars. Sometimes the LFC analyst is present. Okay, I missed Ruby Ann this morning, so perhaps it was covered. I'll rejoin later. So have you had discussions with members of the LFC, either the committee or the agency, for lack of a better word, in terms of trying to up this?
We have had that conversation in some past years with the LFC, but usually it's after I present here, and then either the LFC requests or the chair of this committee suggests to the LFC that they should request.
Okay, and I'm not sure this is the right year for that.
I wouldn't think so.
Everybody's
I think we're very happy to stay flat.
Yeah, I think that's probably everybody out there is praying that they don't lose anything. So, but just something to keep in mind for you to remind us at this time next year, when hopefully the pandemic will be close to the end. Let's hope by the time we get into interim committees next year. So, does anyone else?
Yes.
Oh, yeah, Representative Ferrari, is that who I hear?
Yes, it is.
Okay.
I'm here.
Okay.
I just wanted to, Madam Chair, ask Dr. Larson. I am interested too, and Liz asked some really good questions about the licensing and how that goes into the startups. Is there a way that we could encourage more companies? Because I think my numbers of 34 startups have stayed in New Mexico, and another 60 have gone out of state.
Well, this was the reason why we, not in this committee, but we established the legislature did in 2017, the New Mexico Bioscience Authority. And the New Mexico Bioscience Authority is New Mexico's first public-private partnership where money from the state and money from private investors can be put together to start up new companies. And a presentation was made to STTC. The Bioscience Authority reports to STTC.
And what's that?
The Science,
Technology,
and something committee.
Oh, okay.
and this is not the year for it either. But the idea is that if they could get state funds for direct investment, then they could use that as a way to match in a 2 or 3 to 1 way with larger investors so that they would bring money to New Mexico to invest in more startups. One of the biggest barriers we have for these new companies is having the financing for. You can't go to a bank for one of these new companies. They're pretty high risk. You generally have to go to early stage investors who do that. And we don't have as much capacity in New Mexico as other states, like particularly the coastal states. And so you can attract the capital here if a percentage of the dollars put into these companies could be from the state. The state would also benefit from those by the state would get whatever return from those investments that the investors get. So in some ways, it's an economic model that some states use this economic model. It's not new, but it is a way of investing dollars in a sustainable way. It's not like the film industry where you just give money each year. You put money in, and in a few years, you can get the same amount of money back. Now, you won't get that on all your investments, but you'll get some that work out.
Madam Chair and Dr. Larson, I'm wondering, as we're talking about creating a state bank like they have in North Dakota, if this kind of investment would qualify. You said it was kind of high risk, but
Yes.
I think when you have the investment for New Mexicans too, and also the job creation, that it would be something that we should think about as we're making our pitch to establish a state bank. Dr. Larson, Madam Chair, I also wanted to ask more about, some of the research, like MS, the clinical trials that you have. How is that going? Are there any close breakthroughs or?
Yes. Thank you for the question. So there are about 2,500 to 3,000 people in New Mexico suffering from multiple sclerosis. And almost all of them, at one time or another, has been seen at the University of New Mexico Health Science Center to see what types of drugs might be best for them. Now, multiple sclerosis is an area where there has been tremendous progress in the last 10 to 15 years. So 10 or 15 years ago, there was only about 1 or 2 drugs. And once they stopped working, you didn't have a lot of options if you were one of these patients as your disease progressed. Now, there's more than a dozen that are effective, and that they, and so now you have to really see the specialist to figure out. New ones are coming out all the time. I will tell you, as I mentioned during COVID, we kept our clinical trials areas open. One of them was multiple sclerosis. Well, multiple sclerosis patients have a mild immunodeficiency, so we were worried that they might be more likely to get an infection like COVID. So we put in tremendous COVID-safe procedures for those patients during the pandemic, the peak of the pandemic in particular, so they could keep coming in and getting those drugs. Those drugs are very hard. That you can't just, a lot of those drugs, you can't just go to the drugstore. And so on the clinical trial. And so nobody got sick, and the clinic worked really well. The clinic for the clinical trials continued to work well, and patients in New Mexico continued to benefit.
That's great. Thank you for all of that. Thank you, Madam Chair. That's all.
Okay. Is there anybody else with any questions? And once again, Dr. Roth. I'm sorry. Who was?
Madam Chair?
Yes, Senator Lopez.
Hi. Just, I actually, you asked some of the questions I was wanting a little more information on, so thank you. But I did want to say, Dr. Larson, thank you to you and the team for the work, commitment that you do for our communities. It's so appreciated. I have a constituent of mine who recently dealt with, how would I say, your system, and she just expounds and has no more, how would I say, she has nothing bad to say about UNM, the hospital and the services that she's received. And also she's a patient over at our cancer center also. So it's just, she's...
That's great to hear.
just continuously moving forward and expounding on what you all have done for her and her family. So I just wanted to share that. Thank you.
Well, thank you.
And on that point, Madam Chair and Dr. Larson, our Make-A-Wish kids, are always going up to Albuquerque and to the Children's Hospital, and really appreciate all that, they do for the kids and the parents to accommodate, their successful recovery. So thank you.
You're welcome. Thank you.
And even though we are a little bit behind schedule, and this is definitely off topic, but since I have you, Dr. Larson, I'm just going to put a little bug in your ear about the
Okay.
special needs dental clinic. My son broke his tooth in June, and his first available appointment is April of 21. So we'll talk more, but I'm just this is going to be one of the cages I'm rattling this year, that we can't expect people with disabilities to wait 10 months for emergency dental work. So just putting it out there that that's going to be one of my causes this year. So
Okay.
be prepared.
I'll give everybody the heads up.
Okay, thank you, Dr. Larson. Okay, and now I don't know who. Thank you for presenting and for all you do at UNM. And let me just say that it's great to have all these people. So Ruby Ann says that the Health Sciences Center will present to LFC in December 2020, and I'm assuming that's just your budget, or is that something special?
It's usually the budget. It's not.
Okay.
I mean, sometimes I have a separate presentation from that.
Okay, and then STTC is Science, Technology, and Telecommunications.
There we go. Thank you.
So we're all a little smarter today. Thank you, Dr. Larson, and I will call on whoever's on from Department of Health. Take care.
Thank you.
Larson.
Bye-bye.
Bye. Okay, so do we have Department of Health on?
Yes, we have myself anyway.
Okay, well, you'll be it then. So this is David
David's
Tompkins.
here. Kathy
Okay.
Rock is here. Actually, I'm going to be sharing my screen, and Kathy Rock will be the initial speaker. So
Okay.
I don't know what I need to do to share. Just push the button. No. Here we go.
Yay. We always keep our fingers crossed and hope everything works.
There it is.
Okay.
All right. So Kathy, are you there?
Yes, I was trying to unmute. I apologize, Madam Chairman and members of the committee. I'm Kathy Rock. I'm the Deputy Director of Programs for the Public Health Division, Department of Health. And on this first slide, you will see our FY22 tobacco settlement revenue oversight funding request for the Department of Health. These numbers are slightly lower than the numbers that Ruby Ann presented this morning. And they represent what our FY20 actuals were. There's not a huge variance, but there is a variance between what you saw from Ruby Ann and what we're showing on this slide. As we all know, the tobacco revenue settlement monies are sometimes reduced in the fourth quarter of the fiscal year, and we like to budget based on what we think we're going to get versus what is in the budget, and that's what these numbers represent. And with that, we'll move into the presentations, David.
Madam Chair, members of the committee, thank you for this opportunity to present to you today to share information on how tobacco settlement funds directly help New Mexicans. I'm Beth Pinkerton, manager of the New Mexico Department of Health's Breast and Cervical Cancer Early Detection Program, the BCC program for short. The program works to reduce the burden of breast and cervical cancer among women statewide, with a focus on providing services to those likely to experience disparities. Our program is part of a national effort founded in 1990 by the Centers for Disease Control and Prevention, the CDC, that includes 70 programs in states, tribes, or tribal organizations, U.S. territories, and the District of Columbia. New Mexico's BCC program was one of the earliest, starting in 1991. And in New Mexico, cancer screening services are delivered through a statewide network of providers, allowing individuals to access health care in their own communities. Next slide, please. Approximately 1,440 women are diagnosed with invasive breast cancer, and another 268 women die from breast cancer each year in New Mexico. Because treating early-stage breast cancers found on screening mammography can prevent some breast cancer deaths, the BCC program provides high-quality, age-appropriate, accepted standard of care breast and cervical cancer screening and diagnostic services at no cost to eligible women in New Mexico. Next slide, please. The BCC program provides screening services for both breast and cervical cancer. To be eligible for breast cancer screening services through the BCC program, women must meet the following criteria: be 40 years of age or older, live at or below 250% of the federal poverty level, have no health insurance, and not have Medicare Part B or full New Mexico Medicaid. Approximately 23,164 women in New Mexico would be eligible for breast cancer screening services through our program. Next slide, please. The BCC program prioritizes use of limited tobacco settlement revenue where it is most needed. In fiscal year 20, the program used these funds to provide mammograms, primarily for women ages 40 to 49. Tobacco settlement revenue funds were allocated for 16 providers across the state, with mammography service providers located in each quadrant of the state. Providers agreed to accept Medicare reimbursement rates. Next slide, please. The BCC program received level funding from tobacco settlement revenue in fiscal years 12 through 19, but as Kathy Rock just mentioned, funding was decreased slightly in fiscal year 20. 100% of the tobacco settlement revenue funds are used for direct clinical services. In fiscal year 20, breast cancer screening services funded by tobacco settlement funds were provided to a total of 717 women living in 23 of New Mexico's 33 counties. Tobacco settlement revenue funds help the BCC program to serve more women. At current funding levels, the BCC program is only able to provide breast and cervical cancer screening services to about 12% of the eligible population in New Mexico. And last year, as I mentioned, the tobacco settlement funds allowed the program to serve 717 women who might not otherwise have received a mammogram. Next slide, please. Tobacco settlement revenue funds also help the BCC program to serve younger women. A requirement of the CDC grant is that at least 75% of federal mammography dollars be used to serve women 50 years of age and older. Last year, almost 95% of tobacco settlement revenue funds were used to provide breast cancer screening services to women under age 50. Note that 3 individuals screened with tobacco settlement revenue funds in fiscal year 20 were diagnosed with invasive breast cancers. Another 6 are pending a final diagnosis, and 2 of these potentially could be cancers. Next slide, please. The tobacco settlement revenue funds also contribute to making the required funding match for the BCC program's federal grant. CDC requires a 3-to-1 federal to non-federal match of funds for all BCC programs, and tobacco settlement revenue funds help the New Mexico program to be in compliance with the grant. Next slide, please. The BCC program does not pay for cancer treatment. However, a special category of Medicaid, Category 052, was created specifically to provide access to treatment for women diagnosed with breast or cervical cancer through the BCC program. Medicaid Category 052 is available only to BCC women. All women who are diagnosed with breast or cervical cancer through the program are referred to the BCC program case manager, who approves applications for Medicaid 052 for women living between 139% and 250% of the federal poverty level. Women living at or below 138% of the federal poverty level are referred to their local Medicaid office or the financial specialist at their healthcare provider offices to apply for regular Medicaid. This process functions smoothly in partnership with Medicaid, allowing women to access cancer treatment in a timely manner. Next slide, please. People don't necessarily think of breast cancer when they think about tobacco use. However, there is mounting evidence that both smoking and exposure to secondhand smoke increase the risk for breast cancer. This increased risk is greatest for women who smoked between puberty and first giving birth. In addition, smoking increases the risk of dying in breast cancer survivors. And because of the overall health risks associated with tobacco products, everyone receiving services through the BCC program is assessed for use of commercial tobacco products. Through a collaboration between the Department of Health Chronic Disease Control Programs and tobacco settlement revenue funding, individuals who acknowledge use of tobacco products are referred to the NMDOH Free Tobacco Quit services. Ensuring access to these resources is important, in part because people living in poverty are disproportionately harmed by tobacco use. Next slide, please. The most current data available shows that each year in New Mexico, about 84 women are diagnosed with invasive cervical cancer, and another 25 women die from cervical cancer. While these numbers are not as high as for breast cancer, given the effectiveness of cervical cancer screening at detecting early stage cervical cancers and precancers when they are more treatable and curable, these numbers could be even lower. Cervical cancer screening has contributed to decreased cervical cancer incidence and mortality rates over time. During fiscal years 19 and 20, the BCC program diagnosed 8 women with invasive cervical cancer and another 132 with cervical precancers. Next slide, please. As you know, smoking has been associated with several different types of cancer. The link between smoking and cervical cancer has been known for a while. According to their most recent medical review, the American Cancer Society website states that women who smoke are about twice as likely as non-smokers to get cervical cancer. Tobacco byproducts have been found in the cervical mucus of women who smoke, and researchers believe these substances damage the DNA of cervix cells and may contribute to the development of cervical cancer. Smoking also makes the immune system less effective in fighting HPV infections. In addition, other recent research found that the risk of cervical precancer among persistent high-risk HPV-infected women was statistically significantly elevated at about twice the rate in those who were heavy smokers compared to those who never smoked. To address the increased risk of cervical cancer among women who smoke, as mentioned previously, everyone receiving services through the BCC program is assessed for use of commercial tobacco products, and those who acknowledge using them are referred to the New Mexico Department of Health Free Tobacco Quit Services. Next slide, please. The program is requesting to receive level funding of tobacco settlement revenue in fiscal year 22, and again would plan to use these funds to support breast cancer screening services. Next slide, please. Thank you for your time this afternoon, and thank you very much for helping our program to serve more New Mexicans. I'm happy to take any questions.
Okay, are there any more presenters or? Yes, okay. We will continue until all the presenters are through, and then we'll have questions at the very end, unless there's somebody who has to leave. Okay, all right, then just go ahead.
Hello, everyone. Madam Chair and members of the committee, my name is Joshua Swatek, and I am the Hepatitis and Harm Reduction Program Manager. I'm here to present to you on the, what we've done with our program as an update over the past fiscal year. Next slide, please. As you can see, we are in a very similar situation to the other programs that have presented prior to us. We've had steady funding through the years, and with a slight reduction in FY 20 and 21, and we'll be asking for flat funding in FY 22 as well. Next slide. So we have a combined program, the Hepatitis and Harm Reduction Program with the New Mexico Department of Health. We're integrated. So our hepatitis program has had really quite the year this past year. First off, we continue to test individuals for hepatitis B and hepatitis C. And I apologize for not having more up-to-date numbers. Unfortunately, our lab was a little busy in getting COVID tests. So those numbers weren't quite available to me at the time that we submitted this presentation. But last year, we were able to link 860 individuals into curative therapy for hepatitis C treatment. We do this by accessing our syringe service program. So oftentimes, these individuals are the hardest to reach individuals in our community. There's a large distrust of the medical community, and we use tobacco settlement dollars to fund our contractors to provide these services. We've also fully integrated testing with HIV. So any individual that can provide an HIV test can also provide a hepatitis C test. This has greatly increased the number of people that we have that are available to provide testing and screening for both of these bloodborne pathogens. Also recently, positive antibody tests can now be reflexed to confirmatory viral load tests. That wasn't an option before, but now that's an option for hepatitis C through our public health offices. This allows us to fully diagnose individuals and makes the process of getting into curative treatment much smoother and easier to accomplish. Next slide, please. We're working on an overall elimination plan by the year 2030. In 2016, we were able to provide the groundwork for this with our statewide comprehensive plan and a profile of the epidemic. We started really planning this phase last year. I would say it's July 2020, this is July 2019. The National Governors Association consultation was held in Albuquerque, and our governor was able to attend, and it was the kickoff speaker for that event. This really led us to beginning to ask for various items and to start planning for various areas for eliminating hepatitis C as a public health threat by the year 2030. I know lots of people wonder, what does eliminating hepatitis C? Completely eliminate it. And what we're really trying to do is we're trying to make sure that hepatitis C is a public health threat. So that means reducing the incidence of hepatitis C to where it's rare and that individuals can be treated. Just so you're aware, we estimate about 50 to 60,000 people have hepatitis C, chronic hepatitis C, in the state of New Mexico. A few of the highlights of this program include the partnership with the Mexico Department of Corrections, utilizing 340B drug discounts to treat 2,400 inmates by the end of state fiscal year 2024. We also recently signed an agreement with the New Mexico Medical Insurance Pool to ensure people have access regardless of their ability to be insured. As far as I know, we're the only state in the country that has this capability. Using tobacco settlement dollars, we'll be able to funnel people who are usually don't have any access to hepatitis C treatment through our syringe service programs. We're also going to begin treating hepatitis C at public health offices as a safety net provider in some of our communities that we've identified where there might be a lack of providers, or we could utilize some of the public health efforts in the best way possible. We're going to be kicking this off fairly soon and hope to have our first patients enrolled in October. Next slide, please. The harm reduction program overall, the syringe service program, like I said, we are really focused on preventing the spread of both HIV and hepatitis C. We do this by conducting testing for both rapid testing and conventional testing for both hepatitis C and HIV. We're able to provide our services as an entry point into many different sorts of medical care, not just hepatitis C curative treatment, but also things like substance use treatment, tobacco cessation. It's a place where people trust us who normally might not trust the medical system. We've developed these relationships over the years with our program participants, and they are, they look to us for advice and how to get into some of these treatments. So when those individuals are ready, we're able to make that navigation. We also provide delivery of naloxone to individuals, and not just naloxone, but the education that goes around naloxone. We provide methods about how to reduce the risk of an overdose, how to respond in case you don't have naloxone, and just overall what substances do and how to use a harm reduction method to reduce the likelihood of future overdoses as well. Next slide, please. Our syringe service program, our primary goal is to provide sterile equipment, including syringes and other items, to New Mexicans so that they don't transmit bloodborne pathogens such as hepatitis C and HIV. We've been very successful in this over the years, and our program has grown significantly. We have community drop boxes throughout the state. Most of our public health offices have a drop box where individuals are able to safely dispose of their syringes or other sharps items. And these remove them from circulation. These increase public safety and decrease the amount of syringes that are found in the community. For many years, we were the only safe option for disposing of syringes. Well, luckily, our partners in other areas and jurisdictions have joined us in these efforts. As a part of this, I know that in previous years, there was a concern about the collection rate of how many syringes we were giving out versus how many we were bringing back in. Due to the recent policy changes that we made over the past year, we were able to increase that up to over 90% in this past fiscal year. So we're getting the vast majority of syringes that we give out, we're getting them back. They're being returned to the program to be safely disposed of. Some of those syringes that don't get back, oftentimes they're either confiscated or disposed of in a different manner, such as, people might throw them into a trash service, because some trash services, you're able to do that. And in some of the rural areas, some of the very rural areas that don't have any services, sometimes they're disposed of in other means. As I mentioned earlier, we grew quite rapidly. Over the past 6 years, we had 6,000 people, and now we have over 16,000 participants and over 52,000 interactions with those individuals. Now, many people have asked the question of, does this mean that substance use is increasing over this time? And it could be a little bit of that, but mostly it's because we're reaching into communities that we haven't reached before. We've expanded service options. We have increased training for individuals, and we've increased outreaches throughout the years. So we're reaching more of our community and a higher percentage of individuals at risk. Another really good point of this is that between 84 and 86% of participants have reported not sharing their syringes once they've engaged in the program. As everyone knows, sharing of syringes is the primary risk factor in both transmission of primarily hepatitis C and HIV for individuals who inject substances. Next slide, please. As I had mentioned, we do more than just provide syringes and treatment and options into hepatitis C treatment. We're also looking to engage individuals to link them into medicated-assisted treatment and overdose prevention services. As you can see here, 2/3 of our participants on a yearly basis generally try to make an attempt to get into a substance use treatment center or various types of substance use treatment. But 1/3 of those do experience barriers. And what we can do is we can help work out those barriers, whether it be through providing various services, navigation into Medicaid, or sometimes even on-site initiation of Medicaid-assisted treatment in some of our select locations that have medical components to them. As far as our overdose prevention program, we've also grown rapidly as well. We had 93 overdose sessions in 2020, in fiscal year 2020, which was significantly increased from 2012. And as part of that, we're reaching, our overdose prevention programs are reaching the highest risk individuals for overdose from opioids. So the program has reported over 3,400 opioid reversals in FY19 where the person was okay afterwards. As you can see, that's a significant increase. So these are individuals that may not have survived because their overdose was where they were non-responsive and someone responded to reverse that opiate overdose. So the program has grown significantly over the years. And again, we're reaching more and more community members every year. Next slide, please. As I had mentioned earlier, we are requesting flat funding from FY21. These funds will continue to be utilized for our contracted services throughout the state and to provide syringe services, overdose prevention, and navigation into both Medicaid-assisted treatment and hepatitis C curative therapy. Thank you very much for your time, and I will answer any questions when they come up at the end. Thank you.
Good afternoon, Madam Chair, members of the committee. This is David Tompkins. I'm the interim TUPAC program manager for TUPAC, of course, is the Tobacco Use Prevention and Control Program. And I've got a number of slides here. I'm going to try to move through those quickly and highlight some of the areas that will be updates for y'all. As you know, the tobacco use is the single largest preventable cause of disease, disability, and death. 2,802 smoking-related deaths in New Mexico annually. So it's 1 in 6 deaths in New Mexico are tobacco and smoking-related. In addition to that, over 84,000 New Mexicans suffer with a smoking-related disease. Tobacco is also an economic burden in New Mexico. 1.4 billion plus is the total economic burden of smoking in New Mexico. And that also translates to a $775 tax burden, that's federal and state combined, per household for New Mexicans going toward the impact of tobacco. Smoking adds Mexico's Medicaid, the cost of New Mexico's Medicaid program. We know that 489,000 New Mexico adults are enrolled in Medicaid. That's 3 in 10. And 29% of adults with Medicaid smoke cigarettes. So this is a really important population to us in terms of intervention and offering services, compared to 14% of the New Mexicans with our other type of insurance. When we talk about a target audience, this would be one of our target audiences. The annual cost to Medicaid caused by smoking is a very large number you see up there, $222,800,000. New Mexico communities are using proven interventions to produce positive outcomes. We are very community-based as a program. Some of these interventions include 100% smoke-free policies, including e-cigarettes, access to nicotine addiction treatment services, no access to tobacco by minors, and tobacco price increases. We partner with communities to prevent kids from starting to use tobacco. We do a lot of branding of campaigns. You can look across the bottom there. We have a campaign for each one of these. Tobacco-free rodeo, no minor sale, which takes a look at what's happening at the point of sale of tobacco products to decrease sales to minors. 24/7 is our school policy campaign. We work with schools across the state to implement 100% smoke-free, tobacco-free policies on campus and beyond. We have a tobacco-free campuses New Mexico, which is for post-secondary institutions, colleges, universities. We also work with Know the Risk campaign specifically designed for young people around e-cigarettes. Our involvement campaign, our youth advocates that are out doing education in communities around tobacco use. And a new campaign that just started is No More. This is specifically designed for young adults, ages 19 to 29. Here are just some pins of where different campaigns are across the state. Again, 24/7, you see in blue, those are schools that have adopted 100% tobacco-free policy. No minor sale campaign working across the state as well, tobacco-free campuses and tobacco-free rodeos. We have seen a 70% decline in high school youth cigarette smoking. That's a significant decrease, obviously. 25,300 fewer high school youth smoke cigarettes today than did in 2003. So we're really pleased with that decrease. Two-pack partners with communities to reduce exposure to secondhand smoke and aerosol. A new word here you might see is aerosol. This is when we are referring to secondhand vapor. Vapor is an industry term from the tobacco industry. From a health aspect, we talk about secondhand aerosol. Again, many campaigns that we have working across the state to reduce the use or to reduce exposure to secondhand smoke and aerosol. Some other, again, reducing these through tribes and pueblos. We have a contractor that works specifically in those areas. Since they are not currently covered under the D. Johnson Clean Indoor Air Act, each tribe being its own sovereign nation, we work with them to develop policy to protect residents and community members from secondhand smoke and aerosol. We also do a lot of multi-unit housing work. You can see there with the yellow pins, creating smoke-free, vape-free, multi-unit housing. A lot of times people think, their apartment is just theirs, and it doesn't affect anybody else's of what's going on in there. But the reality is that the ventilation systems and the walls, everything is connected. And so people in multi-unit housing may not smoke. Most do not smoke, but those who do smoke have an impact on other residents within that. We also do Kids for Smoke-Free Air Challenge. This is directly working with younger children to help them to understand the importance of clean indoor air for them, but also to, they work to get pledges from community members and family members to keep their homes and cars smoke and vape free. A real nice success story we have here is with JL Gray. They are a multi-unit property owner here in New Mexico. They're the second largest manager of multi-unit housing, and they're well on their way to and quite committed to certifying that all of its 5,000 units are smoke-free and vape-free by the end of June 21. We have seen another important decline here in terms of high school youth secondhand smoke exposure. Again, from 2003 to 2019, 37,700 fewer high school youth are reporting that they are exposed to secondhand smoke indoors. Two-pack and community partners help people to quit using tobacco. We have a lot of partnerships across New Mexico that also help with this, promoting the quit line and the services that are provided through that. You can see work with a lot of community partners in that important work. But we are more than a quit line. It's always something that we try to help people to understand when they think about TUPAC. They think 1-800-QUIT-NOW. Yes, we do have comprehensive nicotine addiction treatment services in English and Spanish. We also provide a second tier of online trainings for health professionals. We have specific trainings for dental, for behavioral health, and general trainings for all health professionals to know what's available to quit line, but also to know some of the skills of brief intervention and how they can help people through screening and referral. And then the third level of services that we offer through that is our training and outreach program. And this is really around health systems change and going into clinics and hospitals and helping them to take a look at their systems and patient experience from the beginning all the way through, and where is tobacco being addressed, and how are referrals being made, all those types of things, working with clinics and hospitals and such. We do know that 50% of adult smokers want to quit, so that's we know they're out there. They want to quit. Quitting Now improves smokers' quitting success. The use of that quit line, nearly 1 in 3 Quit Now enrollees successfully quits. We offer counseling, FDA-approved nicotine medication, and that more than triples the quit rates. And so we have really an excellent quit line available free to New Mexicans here that offers not only counseling, but also nicotine medication, over-the-counter medications, ensuring a really good quit rate. We have seen a 26% decline in adult smoking. Again, this 77,300 fewer New Mexico adult smokers from 2011 to 2019. In terms of our investment.
Can I just interrupt on
Sure.
that last one? When you
Sure.
say smokers, are you including vape, or is that traditional cigarettes?
This is traditional cigarettes at this point.
Okay, all right,
Talk
thank
a little
you.
bit more about vaping coming up.
Okay, thank you so much.
Sure. Okay, New Mexico invests in tobacco use prevention and cessation. I think everybody's well aware of our funding over the last many years, but this shows we've had pretty level funding for the past 10 years, again showing that slight decrease over that Kathy talked about at the beginning. Our total investment here in tobacco prevention and control, however, is still only at 28% of what CDC's recommendation is. And you can see we have 6.4 million. That includes Indian Affairs Department and also the CDC funding that we get along with the tobacco settlement revenue received through this group here. Where does our funding go? You can take a look there. The thing that we're really proud of is the administration of the MSA funding is only at 4%. We're really pleased to see that just about all of our funding from Master Settlement Agreement goes directly into services, and we follow CDC guidelines for a comprehensive program. Despite successes, we have work to do. We're not done yet, so we have continued to have a high smoking rate among people experiencing poverty, so this is a very important priority population to us. And also, there's a high use of new tobacco products. Madam Chair, this was what you were referring to, and so we'll start getting into that a little bit more here. But among youth particularly and young adults. More than half of the remaining smokers in New Mexico are people experiencing poverty. This represents over 159,000 New Mexicans. So again, this is a very important priority population that we work with. Smokers in poverty are more likely to try to quit, so they want to quit. So that's really an important understanding that 60% of those smokers in poverty have made a serious quit attempt in the past year. TUPAC reaches smokers experiencing poverty. We do that through our systems change trainings. the FQHCs, also our smoke-free policies in low-income housing, offering free coaching and free NRT through the 1-800-QUIT-NOW services. And we also do specifically promote Quit Now to low-income smokers. 60% of Quit Now enrollees earn less than $25,000 per year. Again, that tells us that we're doing our promotion well, that we are people who are in low economic situations are hearing about us and they are using the services. However, there is an opportunity to do more. Through Quit Now, 2PAC serves about 8,000 tobacco users per year. We still have to recognize there are more than 145 smokers who are interested in quitting. E-cigarettes have reversed our gains. So this is kind of certainly something we look at and recognize we have much to do here. We know what works. But now we have this whole set of new products that we have to apply what we know to get the gains back that we have made. E-cigarette use has offset declines in conventional tobacco product use among youth. So you can see in 2009, we had 30.8% of New Mexico high school youth reporting using tobacco products. And the light blue shows the decrease in cigarettes and cigars and spit tobacco, which we're very proud of. The dark blue, though, unfortunately shows us what's happened with e-cigarettes. And our latest data shows us at 37.8% of students using both products. E-cigarettes and other vapor products pose risks. We know that nicotine is highly addictive. It can harm brain development through the age of 25. And so, again, young people and youth are a very important target for us. E-cigarette has aerosol that is not harmless, even though that's how it's kind of presented by the tobacco industry to be. But we know that's not true. Young people who use e-cigarettes may be more likely to go on to use regular cigarettes. E-cigarette used highest among youth and young adults. And so there you kind of see broken down. This is e-cigarettes only, Representative Thompson. So this is getting to that question, what's happening there. 1 in 3 high school youth are using e-cigarettes. High school youth vape 34%, nearly 4 times the rate that they use regular cigarettes. So this is where our challenge lies. New products pose new threats. They require new investments and new policies. This, I always say, I think this is the most important slide for New Mexico to really grasp and for this committee to take a look at and really think through. These are the recommendations of the Surgeon General. I look at this as this is how we can kind of make our own report card. How are we doing here in what we're doing? The first is to raise strongly and enforce a minimum age of sales laws for all tobacco products, including e-cigarettes. Congratulations to the policy that was passed last year, raising the minimum age to 21, also providing licensing, which is now holding retailers and holding the distributors responsible for this and accountable for this rather than criminalizing children. This is a very, very big step for New Mexico. Incorporating e-cigarettes into smoke-free policies. Again, legislated policy that added e-cigarettes to the D. Johnson Clean Indoor Air Act. Very big step for New Mexico. Reducing access to flavored tobacco products by young people. So we have some work to do here, but this is the recommendation. This is what we're working on. A lot of ways to reduce access, and we're looking at that, doing work directly with young people, but also looking at how policy can make a difference here. Sponsoring high-impact media campaigns to educate the public on harms of e-cigarettes among young people. Again, we have some media out there, but we also know this is an area where we could do even more. Increasing the price of tobacco products, including e-cigarettes. Generally, this is done through taxation, but it can also be done through some other means that are happening at the point of sale. So we're always trying to educate people on the importance of this. And requiring tobacco retailer licensure, again, a very, very big win for New Mexico. So two-pack policymakers and our partners, we work together. We can combat the youth e-cigarette epidemic, and we appreciate everything that's been done so far, and just know that this challenge continues. And here are the requests. Again, we know what the general appropriation is last year, and what we're looking for is flat funding here. And I think, looking, the funding from two-pack to two-pack has remained constant. An e-cigarette prevention media campaign could positively impact the growing use of e-tobacco products among youth, and that's what we're looking to complete in the future here. So thank you all. We're so pleased with everyone's on this committee, the interest that you show here, and the developing just really passion for doing this work. We recognize you as really important partners to completing what we need to work on. Thank you.
Thank you. Judith, are you next?
She might be having trouble unmuting.
Okay. I'm sure our crack staff is on it.
Erin, maybe you could unmute her.
Madam Chair, Judith is unmuted.
Okay.
She may need to adjust her microphone settings by clicking the drop down next to mute.
Judith, have you joined us? Judith, if you're having trouble, you might be able to type something into the chat to either Elizabeth, or I'm not sure who should she direct a problem to in the chat?
Madam Chair, that would be to Erin Bond. Me
Okay.
would also be host.
Okay. Well, are you there, Judith?
No, this is Kathy. I
Okay.
know she's here because, Madam Chair, because she was texting me earlier, so I know she's on the call.
Okay. Well, when we have dead time in committees that are live, I ask if anybody knows a joke. So we could, anybody know a joke while we're waiting? Has to be clean. Well, I told this one on the House floor and got a groan, but I think it's a good joke. So let's see if I can remember it. Why does, oh shoot, now I can't remember it. Hurry, Judith, I'm struggling here.
Erin, this is Kathy again. Judith, when I look at her on the list, she looks like she's muted.
Madam Chair, I believe she remuted herself, but I can try.
Okay.
Yeah.
Thank you.
Madam Chair, I'm not sure if she's seeing chat messages. So if it's okay with you, I'd like to just.
Hello, I am calling in on the phone. Can you hear me now?
Yes.
Okay, sorry, I've been having problems with my computer all day. Of course, it had to happen today.
Of course.
Madam Chair, Mr. Chair, members of the committee, thank you for allowing us to present today to show you how we're spending our tobacco settlement dollars. I'm the acting program manager for the Diabetes Prevention and Control Program. Next slide, please. The most recent diabetes data we have is from 2018. The prevalence rates for both diabetes and prediabetes continue to rise. Awareness of both conditions among people that have them is still not optimal, with 8 in 10 aware that they have diabetes and only 3 in 10 aware that they have prediabetes. American Indian diabetes prevalence rates are statistically significantly higher than Hispanic and white. All other race, ethnicity group rates are significantly higher than white. While this disparity has existed for a long time, it has resulted in severe consequences for Native Americans related to the COVID-19 pandemic. Next slide, please. Diabetes costs New Mexico more than $2 billion a year. This doesn't include the personal, emotional, and social costs to families and communities. In 2018, 686 adults died from diabetes, and it remained as the 6th leading cause of death in New Mexico. The age-adjusted diabetes death rate for the American Indian population was statistically significantly higher than that of all other race and ethnic groups, and the age-adjusted death rate of Hispanic and African American populations was statistically significantly higher than that of whites. Next slide, please. There are many risk factors for diabetes, and smoking is one of them. The risk of developing diabetes is 30 to 40% higher for active smokers than non-smokers. Next slide, please. These are our program goals. We aim to prevent or delay diabetes and prevent the complications associated with diabetes and advance health equity in our efforts. Next slide, please. The program's tobacco settlement funds are used to advance the program goals and specifically to reduce the burden of diabetes and its complications through proven prevention and self-management education services, community-based and health system partnerships, professional development of healthcare professionals, and promotion of these resources. About 75% of tobacco settlement funds were allocated for contractual services and 25% for personnel. Next slide, please. DPCP provides proven diabetes self-management education services, including the suite of chronic disease self-management programs previously only offered as in-person sessions. We reached a total of 307 participants overall this past year and did particularly well with the diabetes self-management program. Next slide. Kitchen Creations, a cooking school for people with diabetes, is offered by New Mexico State University Cooperative Extension Service through a contract with DOH. In FY20, there were 17 cooking schools in rural or frontier counties, 3 in Spanish, 11% of our participants were Native American, 3% were African American, 54% were Hispanic, and 50% were age 60 or above. There continue to be high rates of satisfaction with Kitchen Creations, which includes comprehension of material presented and the ability to plan healthy meals. Participants have anecdotally reported increased physical activity, more stable and lower blood sugars, making better food choices, drinking less diet soda and drinking more water, learning many tips on how to make meals, losing weight, and feeling better. Next slide. This is the logo for our referral system, Paths to Health New Mexico. There were 425 referrals to these programs through the system. The diabetes program worked with a contractor to create success stories that highlight the importance of community health workers in diabetes and cardiovascular disease prevention and control, and the Native Lifestyle Balanced Diabetes Prevention Program for Native communities. These are excerpts from the success stories. We focused on these 2 issues because national studies have found that when a community health worker is involved in a patient's care, they manage their hypertension and their diabetes better, including medication compliance, medical appointment attendance, and the reduction of hypertension risk. The success story about Native Lifestyle Balance features a Navajo Nation program participant that became a lifestyle coach herself after participating in the program, changing her lifestyle, and losing 27 pounds. Next slide, please. The diabetes program provides numerous professional development opportunities to its staff and our partners through the New Mexico Diabetes Advisory Council. This past year, the council provided 3 trainings: diabetes in Indian country, nutrition, hunger, and diabetes in New Mexico, and a nephrology or kidney symposium. There was a 50% increase in attendance at the symposium, most likely due to attendance stipends and national speakers. New Mexico Diabetes Advisory Council also sent out 30 newsletters, emails, and updates to its listserv during the year, including the latest updates about COVID-19 and diabetes. Next slide. Tobacco settlement funds also supported outreach in populations that experience diabetes-related health inequities, as well as disease surveillance through the Behavioral Risk Factor Surveillance System, which provides us with diabetes and prediabetes prevalence and other data each year. Next slide. The COVID-19 pandemic has and continues to impact us in so many ways. It raised everyone's awareness about inequities experienced by people of color, both nationally and in New Mexico. Our state's Native populations have been severely impacted with higher case rates, hospitalization rates, and death rates. Prevention and management of diabetes and other chronic conditions is more important than ever, and we must do more to reach populations at highest risk. This not only includes addressing foundational risk factors, but promoting the importance of a healthy lifestyle and working with partners to institute policies, environments, and systems that support people in achieving that. There were some silver linings that came about because of COVID that continue into this current fiscal year. Our contractors quickly figured out how to offer virtual classes. We now know that some people prefer virtual classes to in-person classes, which is a great option for a state as rural as ours or for people who prefer some anonymity. For both the Diabetes Self-Management Program and the Spanish Language Chronic Disease Self-Management Program, we actually surpassed last year's numbers for classes and participants. These were offered in person at the beginning of the fiscal year and then via Zoom and telephone starting in the spring. Kitchen Creation Schools also exceeded expectations. They were offered in more counties this year than ever before because they moved to a virtual format. Next slide, please. We have a lot of staffing changes going on in the diabetes program. We've lost some personnel this year, and we'll be hiring a new program manager, outreach and education supervisor, and health educator who's shared with the Heart Disease and Stroke Prevention Program. The diabetes and heart disease programs are continuing to work more closely together to more effectively address these related conditions. And we also continue to expand partnerships with other organizations with whom we share mutual goals, such as community health worker and pharmacist associations. Next slide. Our funding request remains flat. We will request the same amount as we had in FY21, and we'll continue to use the tobacco settlement funds as we have in the past for 2 DPCP staff positions and our diabetes and chronic disease management programs. Last slide. I want to thank you for your attention today and for your ongoing support for the Diabetes Prevention and Control Program. We truly could not do this work without the tobacco settlement funds. I'm providing contact information for Kenny Viheel, who manages our heart disease and stroke prevention program, because I'm retiring at the end of the month and will no longer be the acting manager. Kenny will be supporting the diabetes program until a new manager is hired. Please feel free to reach out to him. Thank you.
Thank you, Judith, and we're sorry to be losing you, but congratulations on retirement. It's pretty darn fun. Are there any more presentations, or is there someone who wants to wrap up and then we'll go to questions?
I was the last one, Madam Chair.
Okay. Okay, so I have a whole list of questions, but I will wait. Oh, I see. Let me, I'm not so good at the multitasking here. Okay, it was just somebody who said they have to leave. So I will start my questions, and hopefully they are kind of in the order of the presentations. But I have to say the breast cancer one, every time I wrote down a question, the next slide she answered it. So in terms of the breast cancer, I know that we're doing screenings in women under 50, and I'm a breast cancer survivor. I was 41 when I got breast cancer. I'm just wondering, do we have numbers on what percentage of breast cancers occur in women? Well, men too, but in the under 50 population.
Madam Chair, members of the committee, thank you for that question. Unfortunately, I don't have that data at my fingertips, but I would be more than happy to get that for you.
Okay, that's perfect. And then I can't even read my. So when you talked about being able to get onto Medicaid or other types of insurance if there's a cancer diagnosis at 250% of the federal poverty level, but let's say there's somebody at 260%, would they generally end up in the high risk pool, or is there kind of a general path, or is it pretty individualized?
Madam Chair, members of the committee, that is a great question. So it would be individualized, and our programs case manager would work with that individual to help them access the best resource fit for them. So it could be the high risk insurance pool, or it could be other resources through the place where the individual would be getting their treatment, like a payment plan or things like that. So we make every effort to minimize barriers for people so that they can begin their treatment as quickly as possible.
Okay, thank you. And then I'm moving on to the hepatitis C. And I know for years we've heard about how expensive the treatment is, but also that the cost was coming down. So is there kind of an average price of a course of treatment for Hep C? And how does that compare to years past?
Thank you, Madam Chair. Yes, I can't give you the exact prices off the top of my head because those are moving targets, but they have come down significantly. When hepatitis B treatments first came out, they were in the $80,000 range for a course of treatment. Now they're much more reasonable in that $15,000, $20,000 range. So they've come down significantly, and it's going to really depend upon the individual and what medication works best for them, because there's many medications now. There's not just one option. There's several dozen that can be used. So it just depends on the individual circumstance. The one that's primarily used is luckily the cheapest, and it's what we call pangenotypic, which means it works for every kind of hepatitis C. And the average price around that is in that $18,000 to $20,000 range. So it's much more affordable now than it used to be. Okay,
thank you. And do we have a sense? I mean, we hear about outbreaks incarcerated. Do we have a sense of what percentage of folks incarcerated in New Mexico actually have hepatitis C? Just a ballpark.
Ballpark, I would, I can't give you an exact number. I'd have to ask Secretary Toya Lucero for that information. But it is a fairly high percentage of individuals. There's two reasons for that. It's not necessarily because they acquire it in incarceration. It's, individuals who are incarcerated are oftentimes more likely to engage in behaviors that lead to hepatitis C. And also, our corrections department is one of the few corrections departments in the state or in the country that tests everyone for hepatitis C upon entry. So we have a confirmed higher percentage positivity rate because we actually look for it as opposed to some of the other jurisdictions throughout the country. So I can't give you, I don't know the exact percentage off the top of my head, but I can get that for you.
Okay, that'd be great. And this is another example of just not testing doesn't make it go away. So there's one woman in particular, and I don't know her name, but she calls me every once in a while and rags on me till an hour into the conversation, and I say, about needle exchange, that she is totally against syringe she's against the whole program, but what she wants is needle exchange. So can somebody talk a little bit about, just so I have answers when the next time she calls me, about why you've decided to do just, rather than exchange, just provide clean needles?
So we still do an exchange process. We just have a little bit more flexibility and the amount of syringes that we are able to provide. So we're still expecting individuals to bring back syringes. That's something that hasn't really changed. But the reason that we increase that flexibility is because if someone is going through withdrawals, especially for an opiate, if they're going through withdrawals and don't have access to a clean syringe, they're going to use a syringe that has been used before. So if their option is that or nothing, they're not going to choose nothing because opiate withdrawal makes someone very, very ill. Not just psychologically, but physically as well. Withdrawals are incredibly painful and can make people very, very sick. So they will use a used syringe for that temporary comfort of not having to feel sick and go into those withdrawals. So we provide enough syringes that people can, enough syringes for people to be able to use what they need to without having to reuse or share any syringes. And we hand out sharps containers for our program, and we also have those drop boxes throughout the state, and we accept them back in our program. So, I've received those calls as well, Madam Chair, and yeah, that's
Okay.
sort of a misnomer in the community, but we do exchange still. We just have more flexibility.
Okay. All right. Thank you. And then this may not sound good, but I was pleasantly surprised that only a third of people who seek treatment for substance use disorders have barriers. Does that mean that we are near the barriers? Are they payers? Are they beds? Are they services? What are the barriers for that 1/3 of people?
I don't have exact data on that because we didn't go into depth with that question last time we did the survey. But from anecdotal experience, because I used to work in the field myself at a syringe service program, it's a multitude. Transportation is a very large one. Access to housing is another one. There's all sorts of barriers related to, being able to obtain, day-to-day services, day-to-day needs before you get the treatment that folks are looking for. There's payer issues as well, and there's also provider issues, especially in the very rural parts of our community. We work with individuals that are very, very far out of population centers, and for them, it's very difficult to get into any sort of treatment. So those are the primary barriers that they've also seen. There's also a lot of stigma in some communities, so there might be a couple of providers that are willing to provide it, but our program participants don't feel that they're treated well in some of those areas. So those are the most common issues that we have seen in our programs.
Okay, thank you for that. And I think I'm going to move on to 2-pack. So, we've heard on this committee for years that, we all know that tobacco companies are a lot of things, but stupid is not one of them. And so targeting their ads at people of color, LGBTQ communities, people experiencing poverty. So do you have any specific programs targeting those subclasses of tobacco users?
Yes, we do. We have identified priority populations of Asian Pacific Islanders, Native Americans, LGBTQ plus, African American, Hispanic. So we have campaigns and specifically created by those networks that we work with, priority population networks. They provide to 2-pack a lot of advisement about what is the messaging that needs to be out there and how do we really target that messaging to those populations. So it's you think about media as broadcasting. So we do a lot of broadcasting, and you see that on the big media things, the TV and such. But it's the narrow casting is how we approach those other areas with some specific campaigns that we really hand over to those networks, and they help to actually target it within the population that they serve. So it's kind of we receive advisement from those priority populations and then create campaigns that those priority populations can really be the ones disseminating that information into their communities as more of a trusted voice.
Okay, well, that's good to hear. And just a little plug here for Evolvement. Representative Ferrari and I were lucky enough to be able to. I was like a virtual retreat, I guess, and we came in with them and did some roundtables, and those young people are really impressive. So whoever is working on that, kudos to you. I've been really impressed. And then in terms of casinos are off of, we can't do anything about casinos, but there's been some discussion about racinos, about outlawing tobacco use in racinos. Does anyone have any input, anything on that?
Not so much racinos, actually, but we are actually doing work in casinos. So to say that's not the case anymore, it's the tribal casinos obviously kind of set the tone within the state, and then our state casinos takes on the role of having to compete with them. But as the tribal casinos are reopening, they are reopening smoke-free because of COVID. And so we have a contractor with Terrace. They work with the secondhand smoke protections in Native communities, and they're doing a real focus this year on casinos. And with the idea, and this is national, it's not just in New Mexico, but the idea that tribal casinos they're in a really good position now to open smoke-free. They've done a lot of cleaning, and they've been, all of that's been taken care of. And so, and many casinos are opening up smoke-free just because of the COVID issue. The the work that we're doing right now is really encouraging and working with tribes to have those casinos stay smoke-free and make that, beyond COVID. The same thing with the state-owned casinos. They're going to be in it's the same position. Do we reopen smoke-free because of COVID, or do we reopen smoke-free because of the health of our patrons and employees? That'll be the question. So we're doing quite a bit of work right now, particularly in tribal communities around this, and a lot of outreach about why this is really the time to make those casinos smoke-free.
So I guess that's a little bit of COVID silver lining.
Yes, and it's I think it's resonating really well because and it was alluded to earlier. Just the disparities that COVID has made very apparent to us, and tribal communities has just been really racked by this thing, and so their sense of responsibility and ownership around the health of their people, I think, is in a real heightened state. And so, we look at it as being an important window that we want to be able to look at, and we are.
Okay. And then in terms of multi-unit housing, I don't think we have any sticks right now outside of the D. Johnson cleaning, but that doesn't really work in multi. So do we need more sticks or more carrots to deal with the issues in multi housing?
Right now, we're working with carrots, and I think that really is the way to go. It's a different multi-unit housing. They are interested in public health, but they're really interested in bottom line. And so when we can present, what are the benefits to the management and to the owners around smoke-free multi-unit housing facilities, that's where we have our best impact. So we've relied over the years a lot on voluntary policy making within multi-unit housing. Right now, we're working with the Apartment Association of New Mexico, which really is the voice to apartment owners and managers. They're doing really important work now in helping owners and managers to understand that. We have the J.L. Gray, second largest owner here of multi-unit housing, and they're really pushing it, just pushing for this. So I think that what we're hoping to see is that smoking will become the amenity, that the standard will be smoke-free. And, it is resonating with owners that, it costs more to have smoking multi-unit housing. Why not charge more for it? If you're going to smoke here, you're going to pay that extra piece. So that's kind of our goal there right now, is making smoking the amenity, not non-smoking. So that's our tipping point that we're reaching for.
Okay, and then did someone else have something? Okay, I thought I heard something. So in terms
Madam
of
Chair, this is Joanne. I did, but I'll wait till you're done.
Okay. In terms of your quit line, do you track whether people are traditional tobacco users or vapors? I'm wondering how many vapors are now trying to quit.
Yes, we do track that. I don't have that information right here, but I could surely get it.
Okay.
It is still, it's the conventional products that most people are, because our quit line is mostly accessed by adults at this time. And I think from one of the slides, you could see that adults are really not using these products. So they're not needing to quit these products. That's another kind of some of the narrative that the tobacco industry puts out there is, we need these products in order to help adults quit. And they're not using them to begin with. And if they really want to quit, there are FDA approved medications that can certainly serve them just as well or better, and they're free through our quit services. So that's a little bit of perspective, I guess, on that, but I can certainly get those numbers for you.
Okay.
In the last year, we've really updated our services, all of our trainings and everything to include e-cigarettes and secondhand vapor, including our online trainings for health professionals and such. Seeing that opportunity, but the reality is adults don't use it.
That some of the vape companies are claiming that they are putting their products into the FDA for approval as cessation devices. Do you know do you know anything about that?
They have to put it in. They have to show science behind that. It can't just be a claim. And at this point, that hasn't happened. So nothing's been approved at this point.
Okay. And then in terms of, this has been something that we've talked about on this committee for years, is how the MCOs are kind of pushing off some of the Medicaid patients that they should be paying for to quit onto the quit line, therefore leaving fewer resources for people who don't have private insurance. Can you talk a little bit about if we've made any progress, how bad that is?
I can, and I think Kathy Rock could also speak to that. But we have been really closely working with Medicaid over the last year, taking a look at this issue. And Kathy, you want to clue people in?
Yes. Hi, Madam Chair, members of the committee. This is Kathy Rock. And about a year ago, we started participating in a Centers for Healthcare Strategy technical assistance, where Medicaid and Department of Health has come together to work on the MCOs. The issue you spoke of, where they're using our quit line and thereby we're having less resources for others, type of thing. The Medicaid folks, I'm not sure if you've talked to them yet or not, but they have put out a letter of direction to all the managed care organizations that they are using the evidence-based processes that the Department of Health recommends for their client, which one includes quit line, two includes access to the gum patch, those kinds of things, that they will pay for counseling and those kinds of things. So we are working, I think the best thing about this CHCS technical assistance that we received is building those bonds with Medicaid personnel, and working on those issues.
Okay, thank you. And
One
now,
other thing, excuse me, Madam Chair. One other thing that I would say here as well, TUPAC has always been committed to barrier-free resources. So we don't turn anybody away from the quit line. However, when someone does call the quit line, they are asked if they have other insurance, and that's not just Medicaid, but other insurance that also provide services for folks that are addicted to nicotine. But they, at that time, they're asked that question, they still have the option of continuing with the quit line. And many do, because it really is, it's a gold standard here in this country. We have a great quit line. And because it's barrier free, there's not co-pays, there's not any, they just get served. And it's clean and simple. And so, people often opt for those services because of that. But I think, one of the things that TUPAC is trying, and certainly working with Medicaid and with the other insurance companies, to really help them to also be helping their insured folks to understand what the services that they have available to them through those insurance plans. So we talked a lot about benefits today, and what benefits can you get? And so we do try to do our best to refer people to their kind of default benefits under their insurance providers. However, we still would never stand in the way of someone saying, I need help and I want it today, which is what most callers are doing.
okay, thank you. And now I think I'm moving into diabetes. And so when we started doing a lot of telehealth, being a PT, one of the things that I said, oh my gosh, is diabetic foot checks. So do you have any data in terms of we're having more amputations? I mean, it may not have been going on that long, but how we're doing in foot care in these days of telehealth?
From hospitalization data, and it is usually a little bit behind. So telehealth has been around for quite some time. I will see what I can find out about that.
Okay, that'd be great. That was just something that, like I said, as a PT, it's just, okay. And then in terms of risk of diabetes, you said that that tobacco use increases the risk. Is there any research about how vaping, is it all the other stuff in traditional kind of tobacco products, or is it the nicotine itself? Do we have any data on diabetes risk with traditional tobacco products versus vaping?
Madam Chair, Mr. Chair, members of the committee, I do not know. I'm going to see if David may have some information about that.
Okay, and then I just have one more question, and then we'll go to Representative Ferrari. So, are any of your programs using either Project Echo or a Project Echo type of setup with the spoken wheel and training in remote areas? Can you talk of any of the programs about how either you're using Echo or you're using an Echo-like model?
Madam Chair, Mr. Chair, members of the committee, we are not currently working with Echo. We were hoping to engage in some work around telehealth this year, especially with the National Diabetes Prevention Program. The programs that were offered virtually are somewhat like telehealth. They were offered online to groups. And you didn't have to be from the same area. So you could have folks from a couple of different counties. We do not have funding for telehealth this year. One of the things we also are looking at doing is, again, a telehealth type model where you would be able to, let's just say, go to a public health office in Raton with a group of other people, individuals, and have a trainer via telehealth technology out of Santa Fe or Albuquerque. We're not doing that right now. That is definitely an area in which we need to expand.
TUPEC also does not use telehealth, but all of our services are online, available online, and trainings are online. So that's the way that we get information out.
Madam Chair, members of the committee, this is Kathy Rock. And the programs that are represented here today, I believe hepatitis and harm reduction may utilize Project ECHO. And Josh can probably speak a little more about that. We do use Project ECHO for our family planning program, our TB program, and our HIV services program.
Thank you, Kathy. And Madam Chair, members of the committee, this is Josh Swatek again. And yes, absolutely, we utilize ECHO quite a bit. I actually participate in their monthly peer education ECHOs for prisons to provide education for those folks. We use ECHO for treating providers throughout the state. We directly fund ECHO as one of our contracts. They're not using tobacco settlement dollars. So we're very close partners with Project ECHO, especially for hepatitis and HIV throughout our section.
Okay, that's good. And then we've all discovered different ways of doing things under COVID. So some work great and some don't work so well via Zoom or so are all of your programs planning to at least continue when this is all over and done with, who knows when that will be, when we get back to whatever normal will be in the future. Are you planning to continue to use like Zoom type of platforms, maybe to make it easier for rural people to be involved in classes or things like that? Is there a plan to continue this once it's no longer necessary health-wise?
Madam Chair, members of the committee, I'll answer that for the TUPEC program. We're definitely interested in this. It has increased, our reach into areas that we haven't been as successful at before. So right now, kind of our word to our contractors and partners is this is the grand experiment. Let's figure out what works and what doesn't work. Some things just don't work. That's the reality of it. And sometimes I think, especially in public health, people like that human connection. So that's important too. But our contractors have really adapted to this kind of virtual experience, and the quality and the reach of our trainings has really increased because of that. So we'll be definitely keeping those things that do work.
Good.
Madam Chair, Mr. Chair, members of the committee, the diabetes program will continue to do that as well. As I mentioned, we've reached people we haven't reached before. And the program is also planning to put out an RFP for its programs and services for FY22 and intends to solicit proposals for delivery of programs in a variety of modes. So I believe this hybrid is here for the future.
Madam Chair, members of the committee, this is Beth with the Breast and Cervical Cancer Early Detection Program. For some of our non-clinical projects, we're definitely hoping to continue to do some kind of a hybrid model, recognizing that not everybody has access to the technology, as you mentioned earlier today. We are able to reimburse for some services for telehealth currently, based on CDC's permission for us to do that. We don't know if that's going to be something that continues after the public health emergency is no longer in place. But we have heard from some providers that they would like to have that flexibility. So we'll have to wait and see on that.
Okay, thank you all. And I'm going to, Representative Ferrari.
Thank you, Madam Chair. You covered everything so well. I just have one question. or Dr. Tompkins. When you showed the slide about all of the partners, I was looking for some that would cover southern New Mexico for some of your outreach. And did I miss some, or are there some partners here that are helping to get the word out?
Yeah, there are definitely partners. When we look at media approaches, kind of our conventional media, Las Cruces is a difficult area to reach because it's covered more under the El Paso markets. So you don't see the big brand there from the TV companies so much. But we definitely do outreach and have partnerships in the South, and are always certainly continuing to grow partnerships through that. We do have a statewide coalition, the New Mexico Allied Council on Tobacco, and they are also doing specific outreach in the South to bring partners in.
But Madam Chair and Dr. Tompkins, I'm wondering about our media. I know New Mexico Act does a great job of, one-on-one or different groups, but, what about our media? Because I know it is really expensive to go into the El Paso market because it's so huge, but we do lose a lot not getting that visible, that awareness.
Mm-hmm. It has been an obstacle for many years getting into that market. I think I would say, however, we have beefed up a lot of the social media and that type of thing, which does reach into that, and especially with youth. So that is there, but I can certainly make a note of that and look at how, what's available and how can we expand into that area with a stronger presence maybe for the adult market. Again, it's been very tricky in the past. So.
And Madam Chair and Dr. Tompkins, when we passed the DWI laws back in the early 90s, part of what the legislature told us was that we needed to let people know and the awareness. And, so now it would be for underage smoking or vaping, also for retailers. And how much money would you need to, like you said, beef it up, or, how to, increase that, so everyone would be aware that this is the new law and we need to have you abide by it, and there will be consequences for the retailers if they do sell the underage.
Knowing that we're not supposed to ask for money, but
I'm asking.
It would really depend on the breadth of that campaign. I can't pin a dollar amount on it. I might be able to, talk with a contractor about it. I think one of the important things to recognize, we are working with the Alcoholic Beverage Control Group and licensing and regulation to. Because it is their job really to enforce. The No Minor Sale campaign has really beefed up. This is what we're doing. This is what New Mexico has chosen to do. This is what the feds have chosen to do in terms of what's happening at the point of sale. So there's a lot of support there for working with retailers and partnering with retailers. And partnering with the New Mexico Regulation Licensing Department around this. So Evolvement is going to be a strong player in this once the law gets in. The No Minor Sale campaign has expanded to really cover the licensing and doing information. Fact sheets have been created, and those are all available online. So I think the components are there to do that. And beyond that, in terms of, I think it's the e-cigarette piece that maybe would be helpful for getting a more of a kind of a mass media campaign out there around that, because that's. That I think is where we would benefit the most from more resources.
Madam Chair and Dr. Tompkins, would $1 million, if we could secure that from, the permanent fund, and because this is so critical right now when it's going to be, or, when it goes into effect, that it's a critical point to get that information out to people. And so I think if we could ask for $1 million out of that permanent fund, would that help?
Surely, Representative Thompson, Representative Ferrari. Yes, that would certainly help. That would, right now, I mean, that would be a significant amount. Our media budget right now for Quit Now and Dehelo Ya is somewhere around, I think, the entire contract is around 800,000. That $1 million mark would probably be quite incredible. There, yeah.
Madam Chair and Representative Ferrari, this is Kathy Rock, and like David said, we're asking for flat funding for the program, given the, we're also recognizing the current budget situation that the state is in, and we appreciate your efforts to secure more funding, but we are not asking for it.
So, Madam Chair and Dr. Tompkins and Dr. Rock, that would have to be something that we would ask to have put in your budget.
That is correct.
Okay.
Representative, can I just jump in here?
Sure.
Something kind of dawned on me. Do we have, and this is more around 2PAC, do we have anything in our educational standards, particularly health standards, in terms of teaching kids, school-age kids, obviously, anything about tobacco or tobacco prevention? Is that mandated anywhere in our education policy?
Madam Chair, members of the committee, I believe through there's a health curriculum standards adopted by the state that do include some tobacco information. 2PAC does not work in that area. It's not really recognized even as a best practice. So we keep we look more toward policy and environmental norms and systems as opposed to working with curriculum. But I believe there is a health curriculum mandate that includes some discussion of tobacco.
Oh, but it's not best practice.
No, curriculum is not best practice. It's helpful. It may be useful. But as far as a best practice and a high impact, it does not qualify for that, really.
And has that? I'm sorry, Representative Ferrari. Has that been studied in terms of e-cigarettes, or is that more studied in terms of more old-fashioned tobacco?
Certainly, there's more studies around old-fashioned conventional tobacco, Madam Chair.
Okay, thank you. Go ahead, Representative Ferrari. I'm sorry.
Madam Chair, I'm used to tag teaming with you, so that's fine. And that was all I needed to ask, and to get that idea rolling. Thank you.
Okay, any questions from any other members? Okay, I don't hear any.
Madam Chair?
Yes, is this Senator Lopez?
This is Linda.
Oh, okay, go ahead, Senator Lopez.
Thank you. And first of all, I appreciate your line of questions because you hit some good points also for me. So thank you. I did have, and in addition to your request about what's taught to our kids, in my 8-year-old's health class, they have covered with regards to their health, with regards to tobacco. And there was mentioned this last year, not this current year, but this last year, with regards to vaping. It was mentioned by her teacher, so I was like very, very happy to have heard that. So just an FYI.
And Madam Chair, members of the committee, I would also add to that one of the things that TUPAC is doing through our 24/7 campaign, which is the school policy, and then also the work that we do presenting to school boards, parents, and such around e-cigarettes. We also point people in the direction of free curriculum that's available. Schools do ask for it, and they are, they're putting that in. So there are some really good curriculums, and we're working to at least refer people to those, and also how they can incorporate those same type of curriculum into alternatives to suspension for using e-cigarettes on campus. Because the last thing we want to see is kids being sent home for 3 days to sit on their couch and play video games and vape. And so there are some really good didactic approaches that are available, and they're available for free. And we're finding the schools are very interested in that, and we're actually working more as using that kind of technical assistance with schools as another kind of way to promote 24/7 and 100% tobacco-free policy. A lot of times it's easy to put it on paper, but then the schools run into, now what do we do? And so we do have resources that we can send people to that are free and are very well developed. Thank you.
And I agree, Dr. Tompkins, because it was very, or should I say, enlightening for me that she came home, my little one, and she wanted to talk about smoking, and it was laid out perfectly. So I was like, right on, it's happening within our schools. And this is, of course, in an elementary school. And Madam Chair, the other, I think in light of the questions, so I'm not going to ask really any of the in-depth questions because they've already been touched on. But I think most importantly for us to consider is, as we go into session, yes, money will be tight, but I think what COVID has brought to the forefront is with regards to the whole issue on smoking. I've read, and I'm sure everybody else has too, some of the articles that relates back to vaping, and what type of effect that has, because of how it affects the lungs in a very different manner. So I think it's something that we need to also make sure that our colleagues know and understand about the importance of maintaining our monies, how important this is, because it's so related to this, to the impact in many, many communities for COVID. So I just wanted to touch that so that we can keep that in mind as to, as part of that conversation we need to have with our colleagues before and of course during session as we talk about budget, utilizing these dollars. These are so important, I think, and the case has been made today from the questions being asked and of course of the presentations. So thank you. That's all, Madam Chair.
Thank you. Thank you, Senator Lopez. Is there any other questions from the committee? Okay, I want to thank all of you from DOH for great presentations, more food for thought for us about what we're going to, and I'm not letting any cat out of the bag, I don't think, but Representative Ferrari and I are working on a bill to ban all flavors, including menthol. So that's going to be something that we're going to try and do in 2021. Whoever gets reelected, someone will carry this on. And so thank you so much, DOH. And now we're ready to go to HSD. Loretta Cordova, are you on, Ms. Cordova?
There we go. Now I've been unmuted. And let me share my screen. Let's see, I hope this. Huh. Not sure that worked. I wanted it to work. Can you see that as the full screen?
Yes, yes.
Okay, so you are
It's got
seeing it?
Yeah, it's got your slides coming up off to the left, but yes, I'm assuming everyone can see it.
Okay, that's strange. So,
Madam Chair, I'm sorry, this is Erin. If I could just suggest, Loretta, you might want to press the, in the very bottom left, the little square. Oh, I'm sorry. If you go back to sharing your application.
showing the application. Okay.
If you do the presentation view when you share your PowerPoint,
Oh, I see.
that will make it usually a bit more full screen.
Okay.
Thanks, Erin.
Presentation online. Let's see if that works. No. All right. I'm going to try this again. Let's see. I apologize for the delay.
We're all getting used to this. This is, no matter how many times you do it, I got locked out of my Zoom the other day, actually, when it was awards from the ACT network, which was sad for me, but yeah, we all have our technical issues.
All right. Can you see my screen now? I think you can see me, but I'm not sure you can see the
We
PowerPoint.
can see your screen. I think what Erin was saying, Erin, do you want to say that again now that she's got her screen up?
Yes, Madam Chair. If you wanted to do either the from beginning or it looks like present online will also.
Okay.
But from beginning is
Okay, that looks good.
All right. Let me see. Hang on. Hold on. Just 1 minute. Yeah, hold on just a minute. I apologize. Okay. Is that better?
Yes.
Okay.
There's a little gray box on top of next slide, but maybe that's to keep us on the edge of our seats so we don't know what's coming.
Okay. All right. So good afternoon and thank you, Madam Chairman Thompson and committee members for allowing New Mexico HSD Medical Assistance Division to present today. My name is Loretta Cordova. I'm the Quality Bureau Chief and we'll be presenting today regarding programmatic information for Centennial Care related to the tobacco settlement funds. So in FY20, the Medicaid appropriations, I believe that this was presented last year by another colleague in regards to, and again, Ruby Ann mentioned this morning and did a great presentation line by line about the funds from the tobacco settlement program. So a total of $7.5 million was provided to Medicaid from the funds. 1.2 million was provided for the breast and cervical cancer treatment program. And then 6.3 million was allocated for the Medicaid programs. In FY21, we almost looked the same in regards to the allocations for the Medicaid program. Again, 7.3 million was the total amount for the tobacco settlement program fund, utilizing 1.2 million for the breast and cervical cancer treatment program, and a total of 6 million for the Medicaid program. And based on what Ruby Ann said this morning, you know, I think that with the budget, how it's looking now and how most of this is going to go to the program and not have any funds go to the permanent fund, we did see due to COVID and something you said, Madam Chairman, about the silver lining. Not sure this is a silver lining, but we did have an increase in membership. As of June 20th, we had 869,000 total beneficiaries in the Medicaid program for that expansion due to the increase in federal poverty level. So I'm sure we'll see some effect on the Medicaid program as far as dollars spent regarding that. So in this slide, we want to provide you with that the MCOs have a contractual requirement to provide services, treatment products, and counseling services. We authorize FDA-approved pharmaceuticals, nicotine replacement, and services and products as listed in this slide. One of the things that the Medicaid program has done, that's something that Kathy Rock mentioned earlier, was that we did provide for the managed care organizations that they were not to have a requirement for a prior authorization or have any limits on these products. And no matter how many quit attempts they had throughout the year, and there's no step therapy requirement. And the managed care organizations are to encourage members who are quitting into counseling services and supports. One of the things that we've heard from managed care organizations is that the individual counseling is one of the services that members are reluctant to start. You know, I think some folks from the Department of Health spoke about the stigma related to that. And then also most folks really just want to get the treatment products and then go from there. And of course, it's a behavior change. So if people are still more in the pre-contemplation stage of deciding whether they want to quit, I think, you know, that's one of the reasons why the managed care organizations report out that this is one of the areas that you know, members still need to work on. So this slide presents to you the information that we collect at Medical Assistance Division from the managed care organizations. They are to submit a quarterly report to us, and this information is regarding how many unduplicated members are receiving tobacco products and services. And as you can see, in 2018, there were 9,440 members. And then now in 2019, we have 10,946 members, which is an increase of 16%. So as you can see, the utilization from the baseline year of 2016 has increased for members who are receiving these services. I believe that one of the reasons why we saw this 16% increase is, as Kathy Rock mentioned, HSD, the Department of Health, and the managed care organizations started a collaboration late last 2018 to discuss, you know, how do we educate members, how do we get more services out there and to the members, and so that we can start to see more members receiving services for tobacco cessation. This next slide provides you with the total dollar amount. We collect this information on a quarterly basis from the managed care organizations. As you can see, in year 2018, there was total of 1.8 million, and then we increased to 2.5 million. Again, it goes back to the managed care organizations really educating their members on the tobacco use, completing assessments when they're in care coordination to determine if they are someone who uses tobacco in the home, and then really providing information regarding the services that the managed care organizations provide. So between 2018 and 2019, we had a 37% in dollar amount increase. This slide provides you with some managed care organization smoking cessation initiatives that they started as a result of, one, it's contractual, and two, it led to the collaborations between DOH, managed care, and the medical assistance division to understand better how they were meeting the needs of the members. So the managed care requirements require that they educate members on the risks associated for alcohol, tobacco, and other substances. And they are to complete comprehensive assessments and complete prenatal assessments for those moms who are smoking to try to decrease that during pregnancy. So as you can see, there's a variety of information here regarding health promotion, Quit for Life. There's educational workshops. There's support to help members to quit by coaching and that motivational interviewing, and getting folks to do behavior change from support from the managed care organization. In this slide, it's a continuation of the initiatives. Members are working towards care plans with goals and milestones to be created on an individual care plan for that member. So they are working on some type of goal related to this, referring members to individual and group, providing them with the information about the products and services related that are covered under their plan. And then there are other educational materials that are sent out as far as newsletter articles. And then each of the managed care organizations provide information on their websites regarding the smoking cessation programs that they have. In addition, I think it was talked about by the colleagues at Department of Health regarding the quit line. And yes, we do still have some managed care members who are using that quit line. Some of these members do not want to participate in care coordination and just really want to know if they can use that quit line for their support. And so some members, if that's all they want, I believe that they are referring them to that line if that's the only way they're going to seek services. But the other information that's provided by the managed care organizations is their own support system that they have for tobacco cessation. And they enroll members into these programs. And then there's also information regarding smartphone applications and using technology to reach some of these folks who rather use their smartphone. In the younger generation, that might be something that is more attainable and easily ready for them, and that's something that they're used to doing in regards to if they're going to try to attempt quitting tobacco, and this is one way that they like to use that. This really does advise smokers to quit. really helps discuss the cessation medications and then really discussing cessation strategies. This slide talks about some more expanded initiatives regarding the managed care organizations. Again, like I mentioned earlier in those 2 slides with the graphs that they have to submit on a quarterly basis, their information regarding products and service. And the MCOs are by contract, again, have to do these assessments. And as we've mentioned earlier, there is a collaborative between HSD, DOH, and MCOs to work collaboratively, to identify barriers to resolve issues regarding tobacco cessation for Medicaid members. We really want to get the information out to members, and so that we can provide that for them. The last one, Kathy Rock touched on this, is HSD and DOH were selected to participate with the Centers for Healthcare Strategies, an initiative for tobacco focus team that they provided technical assistance to the 2 sister agencies on how they can work together between their 2 services. One, providing, information regarding what is the action between Medicaid and public health, and really providing that peer-to-peer information from other states on how they're creating their tobacco cessation programs, and then how we move forward from a policy perspective to ensure that we have these in our contracts with the managed care organization. The breast and cervical cancer program has been discussed by DOH. This is one of their programs. Medicaid covers the category of eligibility of 052. DOH does do the determinations. They do work with income support in regards to processing the applications and making if treatment is required. And as of July 2020, there's approximately 117 individuals who are receiving treatment under category 052 in the Medicaid program. At this time, that's the end of the presentation, and wanted to know if any of the Madam Chair or members of the committee have any questions.
Okay, so I will go to the, did I hear a little bit out of you, Representative Ferrari? Did I hear a peep?
No, Madam Chair, I raised my hand, but after Gail Chasey did, Representative.
Oh, okay. Okay, I forgot to look at that. I'm still figuring this out. Okay, Representative Chasey. Representative Chasey, are you on? Maybe she had to step away. We'll go to Representative Ferrari.
Thank you, Madam Chair. Thank you, Ms. Cordova. I was wondering, when you mentioned the 869,000 in Medicaid expansion, what was the increase?
I have that information. I just don't have it at my fingertips right now. I don't want to give you the wrong information about what that increase is. So let me find that information out to you and I can provide that.
Okay, thank you.
Did you have more, Representative Ferrari?
Yes, I didn't know if that was going to be now or later and get back to me.
Well, I think so. Go ahead, Representative Ferrari. We'll come back to Representative Chasey.
Okay. Also, is the 1 million, oh no, that's something else. I'm sorry. the MCO's getting money for counseling. How would they, how are they doing their quit line? Is it their own quit line, or is it the two-pack quit line that they're referring people to?
Madam Chair and members of the committee, Representative Ferrari, that's a good question, and that's one of the reasons why there was a collective to get everybody together, because I believe that the managed care organizations are to provide their own internal information regarding a quit line or some sort of program that's related to that. So as a result, I think we have a combination of both after those meetings in 2018, and really working with the managed care organizations to create their own quit line, their own services within, as we're paying the managed care organizations for those programs under the Medicaid services.
Yes, that's my understanding, that they're doing a lot of referrals to the two-pack quit line. And when you were talking about in some of the slides, the breakout that included cessation/services, the counseling services, do you know what that ratio is? Because it could be where they're just saying, we're giving the services of all of the different drugs and things that are supposed to help people, but then all the rest of it is being forwarded and handed off.
Right. So, yes, Madam Chair, members of the committee, and Representative Ferrari. So when we ask them to provide that information, we provide them with the CPT codes regarding the individual and group counseling. However, that is in a lump sum count. So we would have to actually, if we were going to get different information, we would have to request it in a different way.
Okay, and Madam Chair and Ms. Cordova, are there plans to do that soon?
Well, we already have a report that we collect that data. So what we don't do is collect it down to the level that you're talking about. And so we would need to go back and re-review that report and or send a deliverable, what we call a deliverable, to the managed care organizations to do some kind of ad hoc report regarding just a line item for individual and group counseling based on those CPT codes that we've provided for them.
Okay.
So currently, right now, we don't have that information. So it would have to be something that we would have to take back to our department and to work something that we would need to do to provide that information. If you need that information, we can get that for you.
Well, it's not that I need it so much, Madam Chair and Ms. Cordova. It's just that it seems like, and we've been talking about this for a while, that the services, if they're not going to be providing the services for the quit line and for the individual, support, that those funds should go to who is doing that, people who are doing that, I should say.
Right.
So that they can expand and give everyone the, attention and the services that they deserve, instead of trying to make ends meet, which it sounds like the Department of Health is glad to, help anyone who needs it. But if we need the funding to follow the person, not for, MCOs to just collect that fund and then pass it off, besides
Right.
just giving the drugs. So
I'm sorry, Madam Chair and Representative Ferrari, Each of the MCOs are aware that they are to establish their own quit line. And it is in our contract that they are to do that. So we are monitoring who has a quit line. There are lines to call for each of the MCOs. Dr. Scray sent out a press release in June with all of the managed care organizations' telephone numbers, so that if members did need to call in if they wanted to quit, they could call these numbers. We have validated that information, and internally, some of these members are referred to what they would call a disease management program and or their own quit line. I think we have one managed care organization that's a little slower to get to this point, but we are working with that managed care organization to so that we have less and less people like you were referring that are going to the 2-pack quit line and or the New Mexico quit line.
Oh,
and yeah, so we are working towards that, and that was the collective group that we're talking about, where it's medical assistance division, the Department of Health, and the managed care organizations, so that we're working together in understanding, one, the contract, what are the expectations from that contract, and because they are receiving the money from the tobacco settlement funds to provide the Medicaid benefits and services.
Oh, that, Madam Chair and Ms. Cordova, that is amazing. Thank you for getting that forward. And I hope in the next report that might be able to be broken down so we can see that that's actually being implemented, even though you're doing what you can at the state level to impose that. So responsibility. So thank you. I appreciate that.
Sure, no
That's
problem.
all, Madam Chair.
Okay. Okay, can you hear me now?
Yes.
Okay, it was going back and forth without me pushing anything. So I said, sometimes I think Representative Ferrari and I share a brain on this, because she asked a lot of the same questions. And it's exciting. I got a text during this that Dr. Scrace had worked with groups and included from the advocacy groups on getting this done, and I want to thank you. But I also am very cautious, and in that we need to keep track of this and make sure that, I mean, the MCOs are, nonprofit or not, they're about making money. And if there's an easy way to do things a little, not illegal, not, just if it's too easy for them to put off some costs on the state, I'm afraid they will. So I think we just need to stay on top of this. And at some point, and I don't know what kind of data you collect, but at some point, if it turns out that this isn't working kind of on an honor, about actually charging the MCOs or withholding some of their payment for a like amount that was used on the 2-pack quit line, because as Representative Ferrari said, our goal is to get as many people as possible the services that they need. And so if you are on Medicaid, obviously we prefer the MCOs to pay for it, so so just something to kind of keep track of. But I really do want to thank DOH and HSD for working with the MCOs and with the advocacy groups to get this done. And that's exciting news, and we just have to keep on top of it and make sure it's working the best way for New Mexicans who need to. So Representative Chasey, are you back? And I see Representative Ferrari took her hand down. I always forget to do that.
I'm back.
Okay, here you go. Go ahead, Representative Chasey.
Well, my question actually was for Dr. Larson. So do you just want me to say hello?
Oh, well, you can, yes. Introduce yourself. I'm sorry.
I put it in the chat because my hearing was starting, so I put a message in the chat for Dr.
Oh,
Larson.
and I did read that. Let me see.
And so then I have to take my hand down, and I should know how to do that, and I just forgot because I went to my hearing and So I've been listening for quite some time.
Oh, okay. Okay.
And
If you go into participants.
Right, I can do it. I
Okay,
just haven't
okay.
done it yet. I forgot
Okay,
that I had to
okay.
put my hand up
That's okay.
there.
So I think we are through with you, Ms. Cordova. Thank you so much for your presentation. And please take it back to Dr. Grace and other folks that we are really pleased with how you're moving forward on making sure our two-pack quit line dollars go as far as they can. Thank you.
Okay, thank you, Madam Chair and members of the committee. I appreciate your time and your committee to oversee these dollars, and appreciate today. So have a good evening.
Thank you. Okay, I know we're way behind, which doesn't usually happen in this committee, but we have Drew Roybal Chavez from Indian Affairs. Are you on?
Hi, Madam Chair. Thank you guys for inviting me today. Let me start my video.
Okay, take it away. It's all yours.
All right, let me share my screen. There we go. Can you all see my screen? Okay. Just want to make sure you can all hear me, right? Okay. So thank you for inviting the Indian Affairs Department today to present to you on our tobacco cessation and prevention program. My name is Drew Roybal Chavez. I'm the CFO and HR manager for the Indian Affairs Department. I'm just going to jump right into it. So during the legislative session of 2019, House Bill 2 and the New Mexico legislature appropriated $249.3 thousand from the State Tobacco Settlement Fund to the Indian Affairs Department. That the appropriation was to be expended during the last fiscal year, and that it was to be expended on tobacco cessation and prevention programs in Native American communities throughout the state. So the purpose of the tobacco cessation and prevention program in New Mexico Indian communities is to promote cessation and prevention of commercial tobacco abuse in Native communities, and to also promote cultural awareness of the Native traditional and ceremonial use of tobacco as a means to strengthen cultural identity and resistance to commercial tobacco abuse for Native youth and adults. So this is basically the scope that we use when we're preparing our grant programs. So for FY20, these were the grant awards that the Indian Affairs Department awarded. We had 9 grant awards totaling $249.3 thousand in FY20. And these were the tribal governments and tribal serving organizations above. Some of the areas that I'd like to highlight are just some of the projects that went really well were the Mescalero Apache tribe, which is the 7th item on here. The tribe basically uses the CDC curriculum for commercial tobacco cessation while teaching the importance of traditional tobacco usage to youth in the community. So one thing that I really wanted to highlight about this project is not only do they, focus on CDC curriculum and ensuring people understand the risks of smoking, but they do also teach their youth how to grow tobacco for some ceremonial use and what that means within their community. So it's a really nice way that they get the youth involved to understand how dangerous commercial tobacco is, but how important ceremonial tobacco use is in Native communities. Another area that is the Oso Vista project. This is a really great project that we have with Oso Vista. They have, I don't know if you're all aware of the comedian Ernest Sosi. He's a Native American comedian. So he basically went out to, or was going to go out to 30 to 40 different communities, which include Navajo, Pueblos, and the Apache communities. And he was giving a comedic, but also educational presentation on the dangers of commercial tobacco usage. We've seen that that's really a great way of engaging the youth, and in a comedic way, but also showing them just how important it is to be safe and to not use commercial tobacco. So we had, like I said, these 9 different projects. We had some with Pueblo of Acoma. We had some tribal serving organizations as well, like the Albuquerque Area Indian Health Center. But the overall scope of work for all of these grants was to provide commercial tobacco cessation outreach. So there's many different ways that they can do that, and that's kind of outlined in these different areas here. And all of our grants, just so you know, we run them through a granting process, so they have to apply for the grant. The grants are not to be more than 50,000 each, and they go through that process where they're rated, and then that's how they end up getting these amounts here. And we do intergovernmental agreements and contracts to get these funds out the door. So there were some impacts, obviously, due to the pandemic with this grant program. The main thing that I would say is that all of these events were supposed to be outreach events. So that's, going out in public and having events, whether they're at, events in the tribes, or going out to health fairs and, trying to just to get the word out there about the dangers of smoking. So one thing we had to do was work with all of the grantees to revise their scopes of work to include virtual events instead of in-person events. There were some grantees that weren't able to revise their scope of work due to the time, or they just were not able to do that with their community being closed due to the pandemic. But so of the total 249.3 thousand, there will be a reversion of 19.8 thousand back to the Tobacco Settlement Fund, and that would reflect the scopes of works that were not able to be completed, basically due to the pandemic. We are ensuring that our FY21 scope of works that they are able to be completed remotely to avoid any further reversion, so that basically any projects funded this fiscal year will not be, not able to not be spent. So the next thing, so our FY21, FY22 funding, IED did receive 249.3 thousand during the last session. We thank you for that funding and for keeping our program running. Our notice of funding availability is currently posted on our website. We're accepting applications for the 2021 funding cycle. So this NOFA will close on October 4th. So if any of you all are aware of any tribal governments that would like to apply for this funding source, please send them my way. But we would love to have some new grantees as well. For the FY21 budget request, we included a flat budget request of the 249.3 for this grant program as well. We're not requesting any additional funds in the upcoming fiscal year, but we're working really hard to just spend down what you guys are sending our way, and we really appreciate your support in all of this work we do. And that's really the gist of what we're doing. You guys have any questions for me?
Okay, thank you so much. Are there any questions? Well, as usual, I won't have many this time though, and you may not have this data. Are Native American kids kind of following the same trajectory of e-cigarette use as non-natives? Have those rates risen at commensurate levels with other communities?
Well, I apologize, Representative. I actually don't have that data with me right at this point. One of the things about IED that makes us a little different is we do provide services that are obviously targeted towards tribal governments, but we're a real small department of about 17 staff, so we don't really have a health educator on staff right now that pulls data for us. So a lot of the data we do get from the Department of Health, the New Mexico Department of Health. So,
okay.
So I apologize that I don't have
Yeah, no, I wouldn't expect it to be different necessarily. No. Representative Ferrari, do you have questions?
Thank you, Madam Chair. Not at this time. I'm really sorry that they had to revert some of the funding, but I'm glad that some of the groups have been able to still meet and do things, especially with the youth. Even if it's virtual, I think it keeps young people connected and going forward till we can get out of this pandemic and back to work. So thank you.
In terms of that, in terms of reverting the money, do you have a sense that some of it may have been due to lack of connectivity, either for the actual grantees or their target population? Do you know how much of that was an issue?
I don't think, Madam Chair and Representative Thompson, I don't think that we have anything per se to say that. I would think the areas that the funds were reverted were mainly due to the fact that those specific tribes had everything closed down, like their government was closed down, everything was closed down due to COVID. So I think that was really what delayed a lot of that and didn't allow them the time to spend down the funds. I will say the 249.3, and then you take the 19,000 out of that. I mean, they did a pretty dang good job spending down considering where we are And I will say this program since I've been at the Indian Affairs Department, I've seen that these grantees do a really good job of spending down. So I know this reversion is definitely higher due to just governments being closed and really also just having the lack of being able to figure out how they could get people together so quickly. So, but
and Madam Chair, it's also,
go ahead, Representative Roy.
I'm sorry, it's also, obvious to us all of these things that COVID has, made so obvious, like the interconnectivity, not having the internet available to everyone that they need to reach. So as we're contemplating how we change this for our whole state, if something comes up again, it'll maybe even help young people and adults to be able to connect better. That's all. Thank you, Madam Chair, and thank you, Drew.
Thank you, Representative Ferrari. And I asked this question of the other departments. Does IAD plan to continue to allow your grantees once we are under a non-emergency order anymore and things get back to whatever new normal looks like? Are you going to continue to have this as an option for your grantees to do things virtually?
Madam Chair, I appreciate that question. I think it's a great option. I don't see why we would not entertain that option. I think, like in the past hearings that I was listening to, I think, like you said, it's a good point that there are so many people, spread out throughout the state that this really does allow us, a separate part of the population, to participate in our projects. So I do think that we would definitely be open to keeping this format, basically either or.
Okay, that's great news as far as I'm concerned. Senator Lopez, did you have any questions? It's down to the three of us, so I'll just, or maybe Representative still on. Do you have a question, Senator Lopez?
No, I'm fine. I appreciate the information shared, but if I may say, just tag on to your questions with regards to how we can utilize the internet, since it's kind of forced us into this venue. That may be another option that should be kind of that hybrid mode for participation. I think that's a very good suggestion.
Thank you, guys.
Hybrid right now too, so hey.
Okay, Representative Chasey, do you have anything? Okay, I think that's all we have. Thank you so much for your presentation. It was great. It gave us a lot of good information, and thank you for your work, and thank all the folks in your department who are doing this important work.
Thank you, guys. We appreciate all that you do for our department and all of the support we get from you every year. So thank you. I'll definitely share that information with our department. Have a great day.
Okay, thank you. Okay, and so Elizabeth or Aaron, I'm not sure who. Do we have any public comment?
Madam Chair, no, we do not.
Okay. So I think we're not an official anything, so I can't even. Senator Lopez, do we need to adjourn since we are just a subcommittee? Yes. Okay. I'll entertain a motion to adjourn. Oh, and I want to thank all the staff, anyone who listened in. Things are kind of different, but we're still getting our work done in half the time. Theoretically, we have half of our meetings, so we're trying to do all of our work. So I will entertain a motion to adjourn.
I so move. And
Okay.
I'd like to thank staff too. It's like they outnumber us so, as panelists. So thank you for being here.
Okay. Is there any opposition to the motion to adjourn?
Nope.
Okay. Take care, everyone.
Thanks, everybody.
Okay. Bye-bye.
Thank you. See you next week.
And see you soon.
Yes.
Bye.